Last week, Sutter Health announced it's absorbing Alina Health, a Minneapolis nonprofit, to create a $26 billion 39 hospital system stretching from Sacramento to Wisconsin. The press release was immaculate. Bold vision for nonprofit healthcare, AI and digital health tools, $2 billion investment in Minnesota. Every healthcare journalist in the country ran the same angle. This isn't your grandmother's hospital merger. This is about technology. That's a lovely story. It's also worth examining very carefully because the last time Sutter Health talked about what was best for patients, it cost him $800 million in antitrust settlements. To understand why this deal matters, you need to understand what Sutter Health actually is, not the version in the press release, but the version that spent 2 decades in court. In 2000, the California Attorney General sued Sutter Health to block its acquisition of Oakland's Summit Medical Center. That kicked off a legal saga that would define healthcare antitrust litigation for a generation. The core allegation was straightforward. Sutter used its dominant position in Northern California to force insurers into all or nothing contracts. Want access to our flagship hospital? Fine. You also have to take every facility in our network at our prices. The result, healthcare costs in Northern California ran 20 to 30% higher than the rest of the state. In October of 2019, on the eve of a 3-month jury trial, Sutter settled for $575 million and agreed to 10 years of behavioral restrictions under a court-appointed monitor. Then in 2025, a separate federal class action added another $228 million. That's over $800 million in antitrust liability. Not for billing fraud, not for malpractice, for being too good at consolidation. Which raises the obvious question here. When a system with that track record announces it's expanding across state lines in the name of AI, should we be impressed or concerned? Let's be fair to the deal first. The stated rationale is genuinely interesting. Sutter sits in Northern California, proximity to Silicon Valley, deep investment in digital health infrastructure, where we like to work, one of the more technologically sophisticated health systems in the country. Alina sits in Minneapolis, the heartland of medical device innovation. We're talking Medtronic, Boston Scientific, 3M Health. Minnesota's healthcare technology ecosystem is arguably more consequential than the Bay Area's, just less flashy. The pitch is that combining these two ecosystems creates something neither could build alone. A platform that marries AI development capabilities with medtech engineering heritage. Sutter CEO Warner Thomas calls it creating a model of how nonprofit healthcare should work in America. And to their credit, the structure is unusual. This isn't a cash acquisition, it's a nonprofit to nonprofit combination. Alina keeps its name, its Minneapolis headquarters, its board, even its CEO. Lisa Shannon stays in charge, reporting to Thomas, and Sutter is committing $2 billion in new investment across Minnesota and western Wisconsin. New ambulatory care centers, specialty care, physician recruitment, virtual care expansion. Compare that to the typical hospital merger playbook. You buy the system, you cut 15% of the staff, you consolidate service lines, you raise prices. This deal, on paper, is the opposite. More investment, not less, more physicians, not fewer, and technology, not leverage. If you take the press release at face value, this is healthcare consolidation 2.0. The version where scale serves innovation instead of pricing power. But here's what people miss about this deal. The genius of cross-market, non-contiguous mergers is that they're almost impossible to challenge on traditional antitrust grounds. The FTC evaluates market concentration within defined geographic markets. Sutter dominates Northern California. Alina is significant in the Twin Cities, but there's zero overlap. No market in America gets more concentrated because of this deal, which means the $800 million in antitrust settlements, they're largely irrelevant to the regulatory review here. Minnesota AG Keith Ellison has broad authority to evaluate whether the deal serves the public interest, but he's evaluating a $2 billion investment promise, not a market concentration threat. This is structurally brilliant, and it's worth understanding why. The old consolidation playbook, buy your neighbor, control the market, raise prices, has a ceiling. Regulators eventually catch up. Sutter learned that lesson at a cost of over $800 million. But cross-market expansion, that's a different game entirely. Here's what $26 billion in combined revenue actually buys you. Purchasing power over medical supplies, pharmaceuticals, and technology platforms that no single market system can match. When you're buying Epic licenses, AI infrastructure, or negotiating with device manufacturers for 39 hospitals and 400 care sites, the per-unit economics are fundamentally different. The real insight is buried in the financials. The $2 billion investment in Minnesota isn't charity, it's the cost of building a platform that generates returns at scale. Virtual care infrastructure that serves 5 million patients costs the same whether you have 2 million patients or 5 million patients. AI models trained on Northern California clinical data become even more valuable when they're validated against Minnesota patient populations. I could be wrong about this, but I think the technology narrative is both genuine and strategic cover at the same time. These aren't mutually exclusive. There's a fascinating angle of the union response that I'm not going to get into here. SEIU, the Nurses Association, and the Doctors Council have all raised pension obligations and contract continuity. I'll put the full breakdown of that in the subtext post for this episode. So, is this actually different from traditional consolidation? Let me give you 3 reasons to believe it is and 2 reasons maybe to stay skeptical. First, the investment thesis is real. This is not vaporware. Sutter has been deploying clinical AI for years. We're talking ambient listening in exam rooms, predictive models for patient deterioration, automated prior authorization. The Star Tribune reported this deal will likely boost AI usage in Minnesota healthcare. That's not marketing. Minnesota health systems have been slower to adopt clinical AI than coastal systems, partly because the investment economics don't pencil out for mid-sized nonprofits operating independently. Second, the nonprofit structure matters. In a for-profit acquisition, the buyer needs to extract returns for shareholders. In a nonprofit combination, the returns are reinvested. That's not nothing. It changes the incentive math on whether you optimize for margin or mission. Third, the $2 billion commitment is contractually binding. It's not aspirational. Minnesota's AG will likely condition approval on enforceable investment benchmarks. That's regulatory leverage that didn't exist in Sutter's California expansion era. But are there reasons to stay skeptical? Well, first, technology consolidation can be just as anti-competitive as geographic consolidation. It just takes longer to manifest. When one system controls the AI platform, the clinical data, the physician network access across multiple states, the switching costs become enormous. Payers who want to offer narrow networks or steer patients to lower cost providers find their options shrinking not because of geography, but because of technology lock-in. Second, Sutter's behavioral restrictions from the 2019 settlement, they expire in 2029. That gives Sutter 3 years of operating a cross-market mega system while still under a court-appointed monitor. And then the guardrails come off. The timing is not coincidental to me, because nothing says we've learned our lesson like expanding to 39 hospitals while your antitrust monitor is still checking your homework. If you're an employer in Minnesota or Northern California, here's what this looks like on your renewal quote. Probably nothing for now. The deal doesn't create new market concentration in either region, so the near-term pricing dynamics really don't change. But the medium-term picture is more nuanced. If the AI investment thesis works, if Sutter Alina actually deploys technology that reduces administrative waste and improves clinical outcomes, that's genuinely good for the system. Lower readmission rates, faster prior authorization, more efficient care delivery. Employers benefit from that. The risk is the scenario where technology becomes the new moat, where the AI platform becomes so integrated into the clinical workflow that no other system in the market can compete on capability, and employers' choice of healthcare system becomes theoretical. That's the same dynamic Sutter created with its all-or-nothing California contracts, just dressed up in machine learning instead of contract clauses. For benefit leaders and CFOs, the action item is straightforward. Watch the investment benchmarks. If Minnesota sees new ambulatory care centers, expanded virtual care, and measurable quality improvements over the next 3 years, this deal is working as advertised. If instead you see service line consolidation, physician practice acquisitions, and narrowing referral networks, you'll know the AI story was just the wrapping paper and not the gift. Healthcare consolidation isn't dying, it's getting smarter. The old playbook was crude. You buy hospitals, you control markets, and you raise prices. The new playbook, well, it's elegant. You buy capabilities, you build platforms, you create switching costs that regulators can't easily define as anti-competitive. The Sutter-Alina deal might genuinely be different. It might be the first major consolidation where technology investment is the actual strategy, not just the talking point. But I've covered healthcare long enough to know that the most dangerous mergers are the ones that sound the most reasonable. The best predictor of future behavior is, well, past behavior, unless the incentives actually change. The $26 billion question is whether they have. If you found this useful, hit subscribe. The research resources and the full union analysis are going to be in my Substack, and the link's in the description. And until next time, I'll see you then.